human medicine. This is Dr. David Spiro. I'm a professor of pediatric emergency medicine at Arkansas Children's Hospital, and excited to share more stories and throughout my own personal journey in exploring the human side of medicine, things that folks don't really know about, what doctors and healthcare professionals go through in the crazy world that we live in when we practice the field that we're in, whether it's peds emergency medicine or other fields. And so today I'm incredibly delighted and honored to present Dr. Don Arnold, who is not just a colleague, but he's one of my closest friends. I almost consider him a brother to me. He's a mentor. And in the Yiddish word, we use the word mensch, which is just a really good guy who just seems to know how to do the right thing all the time. And so I'm just incredibly honored to be your friend, most importantly, and have you as a guest on HUMED.
Privilege and an honor to be here. I thank you for inviting me.
And full discovery, when I first asked Dom a month or two ago when I started this, he said, "David, absolutely not. I'm not going to do it. It's okay." But he heard a few episodes and he came around, but there's no forcing here because unfortunately we don't live in the same city, so I can't twist his arm literally. But Don, I was hoping maybe you can just tell our listeners how you got here today, because you have a very unusual journey to being a full professor at Vanderbilt University.
Well, sure. I'm a bit of an itinerant. I grew up within sight of the Kennedy Space Center in a small town in Florida. Could see all the launches from my front yard. I went to college and medical school in Atlanta at Emory and completed a pediatric residency at University of Virginia in Charlottesville, and then fulfilled a U.S. Air Force obligation because they put me through medical school. I spent the first 2 years at a remote base that had B-52 bombers and cruise missiles and tankers to refuel them in flight. That was a great experience. And for our listeners who are familiar with the military, there are actually more dependents in the military than there are active duty. So that was a very active, busy practice. I had a partner, pediatrician. We were on call every other night. It was a great experience. The second 2 years I spent at Patrick Air Force Base in Florida, home of the 45th Space Command. And just in case you're not aware, there was a Space Command before there was a Space Force instituted by our president. I then practiced community pediatrics in a rural setting in Florida for another 13 years. And after that, returned for fellowship training in pediatric emergency medicine at UAB in Birmingham, where I met David. I returned to fellowship to learn a new trade. I wanted to buff up my clinical skills and do something different. But David interested me in clinical research, which I'm very grateful for. From UAB, I finished fellowship and became on faculty here at Vanderbilt at the Monroe Carroll Jr. Children's Hospital here at Vanderbilt. And initially had an interest in pulse oximeter technology, which David and I collaborated on and obtained a couple patents. It was a great experience. But that sort of evolved or matured into an interest in acute asthma, which has been my research interest for the last 15 years. Um, so that's how I came to sit where I sit today.
And just to top it off, I know you're an incredibly humble person. You achieve something that very few people achieve in our field in pediatric emergency medicine, as you have federal funding to study asthma and some innovative therapies to help treat children who suffer from acute asthma, and doing some of the most advanced research in the field. And for those of you who do not do research, getting an NIH grant and federal funding is no easy feat. And oftentimes it takes years and years and years to achieve that. And that's just icing on the cake. So, what a great story. And I would love to now turn the table back to you. And I know that you have a phenomenal story to tell and would love to have you share that with our audience.
Well, thanks, David. This is a story in which I learned a great deal by making a mistake. Um, in training at UVA in Charlottesville, it's a very beautiful place, wonderful place to live. Spend 3 years as a resident. There is a camp called Camp Holiday Trails, which was begun by a pediatric pulmonologist and endocrinologist in the mid 1970s, initially for children with profound hearing deficits, diabetes, and cystic fibrosis. And I think since then it has expanded to include children with multiple other medical problems. But the goal of the camp was to allow these kids to have a normal, happy summer in which they can forget about their chronic disease. Um, as one of your previous guests noted, sometimes our goal as pediatricians, he was an internist, but as pediatricians, one of our goals might just be to help the patient and parent develop memories. And Camp Holiday Trail served that role very well. I One of the campers was a little girl, 9 years of age, with cystic fibrosis, who I'll call Nina. That's not her real name. But CF, or cystic fibrosis, is a condition in which the mucus in the lung and airways is very thick, unlike normal mucus, which is almost watery, so it can move infection and foreign debris out of the lungs. This thick and sticky mucus leads to chronic bacterial infections and recurring exacerbations with injury to the lungs and ultimately respiratory failure and an early death. And at that time, in the early 1980s, most of these children died in childhood or early adolescence. Um, and at the time I served as a camp doctor, the primary treatments were measures such as chest percussion, in which we would try to free up mucus so the child could expectorate it or get rid of it. Um, and then antibiotics, both chronic antibiotics and more intensive antibiotics when they had an exacerbation. Since then, there have been amazing advances in the treatment of cystic fibrosis. It's one of the monumental achievements of modern medicine. And as an aside, I will mention that it's a monumental achievement of federal funding through the National Institutes of Health. But in particular, there's been the development of a class of drugs called CF transmembrane conductance regulator modulators, long term, whole mouthful. But these target the underlying genetic defect and lead to a much more normal mucus, more normal lung function, improved quality of life, and ultimately much longer lifespan rather than these children living into their late adolescence. People now live into the 70s. Unfortunately for Nina and the other kids with CF at that camp in 1982, these treatments were decades away. Camp Holiday Trails made possible, as I mentioned, a normal summer for these kids. And oh, did they have fun? These kids really know how to have fun. I the camp was a Serving as the camp doctor was an elective for second and third year residents, and I was fortunate between my second and third year residency to be chosen to be the camp doctor. It all went well. I learned a great deal. And then the next Christmas, I received a Christmas card from Nina, in which she told me how school was going and how much she was looking forward to camp the next summer. As it turns out, between the end of my residency, the end of my third year, and my entry into the Air Force, I had a month of free time. They were looking for a doctor for that summer. I volunteered and was fortunate enough to be the camp doc a second year. After that, I entered the Air Force, and as I mentioned, I was at a remote station with B-52s and cruise missiles with one other pediatrician who served as a mentor to me. He helped me assimilate much of what I'd learned in residency. We had a busy nursery and inpatient unit, and we're on call every other day. Um, but a couple years into my time as a pediatrician at that base, I received a letter from Nina's mother. She explained that Nina had died and that she had asked her mom to make sure she let me know, including how much fun she had at camp and how much she appreciated how we treated her as a kid at camp and not a kid with CF. At the time, I was busy, as I mentioned, on call every other day, every other night.
And how old was she when she passed roughly? Was she a teenager?
She was 11 years of age.
Yeah, because today with current therapy, most people with modern treatment today can live into their mid adulthood, maybe even to late adulthood, we think, with some of the new therapies.
Right. They were, as I mentioned, they were decades in the future at that time. And in particular, these CFTR um, drugs have increased lifespan. My understanding is the median age when people are on these drugs is now in the early 70s. Just remarkable, just amazing. But sadly, Nina did not benefit from that. Um, but I received this letter, and it was sobering and sad for me because she seemed to be so healthy at camp. Um, and as I mentioned, I was busy, and then this is where the negative aspects for me as a pediatrician begin. I put the letter in my desk drawer, forgot about it until about 5 or 6 years later. As I was cleaning out the desk, I found the letter, felt very bad about it, and wrote to Nancy's mother. My letter was returned as undeliverable, and I felt guilt and shame for that. I'll come back to that in a moment. Um, and then years later, in the late 90s, when the internet came into use, I Googled the mother's name and town and found her obituary. And as it turns out, she died the year I had finally returned her letter. It was one of those things I just missed the opportunity to respond to her and to acknowledge her love and her feelings for her daughter. Um, so, needless to say, I felt a great deal of actually shame and guilt, um, and I tried to learn from that. And I anticipate most of your listeners will hear this story and think I'm the most insensitive, selfish physician imaginable. We're, we're all a mix of good and evil, and I'm no exception. And on that occasion, I moved the dial toward toward evil. Um,
Oh, I think you're being too hard on yourself, honestly. I'm just gonna say that. Um, maybe we could just I want to hold in that moment because there's so many things that come to mind. You know, it's funny because you first said initially you used the word before you even started the story. You preluded it with you said you made a mistake. Um, could there be other lenses to this around? Maybe you were busy. Maybe there was a subconscious decision to compartmentalize the pain and grief that you were feeling around this child. And yes, you missed an opportunity, but you made it an effort, which I do not know if most of my colleagues would have even responded or felt the need to respond. Um, and the way you feel about it, I think, says a lot about who you are.
David, this certainly was not my first medical mistake or error, and certainly not the last. But I do view it as a mistake,
Mhm.
and I tried to learn from that by mindfulness and introspection. And I'd like to think I learned and grew as a person and as a pediatrician. Um, when a patient reaches out to us or a parent in that way, because as pediatricians, we all acknowledge that we have both the patient and the parent or parents. But when a child or a parent reaches out to us like that, I think we have an obligation to respond. That's self-evident. Um, but I did try to learn from that and to make sure that that particular mistake did not happen again.
You feel like there was a learning opportunity here and maybe there's some more mindfulness or a sense of being present with your families when they're undergoing really difficult situations. So, at that point, you were at the beginning of your career. Now you're towards the end, and you're also a pediatric emergency medicine physician. So, uh, take what things about this case had changed the way you are and the way you interact with patients?
Well, first off, it helped me better understand that when we step into a patient's room, whether it's in a clinic or in the emergency department, we are really stepping over a sacred threshold. It's a special relationship, particularly for pediatricians. Um, one thing I learned, one behavior I changed is that when I was in the military and in private practice in a small town, I made sure to attend the funeral of every patient I had who died. Fortunately, in pediatrics, we don't lose too many patients, but um, I think that is one of the most important gestures that we make toward a family when they can see that this means enough to the pediatrician that they're there. So that's one thing I learned. And I have tried to attend memorial services and funerals for as many patients who I've had die in the emergency department as possible. It's not always possible because of our call schedule or our shift schedule and the fact that many of the children coming to a tertiary children's hospital come from hundreds of miles away. So it's just sometimes not possible. But that's one of the practices I've incorporated that I think is highly worthwhile.
This is again unusual. I think very few of my colleagues do that, and I think it's beautiful. What when you've attended funerals both as a general pediatrician and now as a pediatric ER physician. What um, what do you take away from going to these services, and what do you experience as a human being?
Well, I certainly experience sadness and a sense of loss, uh, as we all do when a patient or a family member dies. Um, but I also experience a sense of closure, which hopefully these services are the beginning of closure for families, but also they provide us a sense of closure as well.
You had shared with me prior to uh, our chat today that you also at one point gave the eulogy for a family. Is that is that true?
Yes, as it turns out, if you fast forward from the early 90s to the early 80s, 1980s to the early 1990s, I had another patient with cystic fibrosis who whose family I became close with, and I was her primary pediatrician. Um, it happens that she was the same age as Nina, and I'll refer to her as Jillian. Um, it's a very sad sequence. She had deteriorating lung function in her mid-teens, and the family and our community hired a professional fundraiser that made possible raising enough funds for her to have a lung transplant, which was successful. And then in her early 20s, a plastic surgeon performed a breast augmentation. And I was not aware of this until that time, but apparently there's very significant chest pain um, for a couple weeks after that kind of surgery. With that degree of pain, her pulmonary function deteriorated and she died. It's very shocking, disturbing, um, unexpected, and just wrenching to the family. And it happened that they asked me to deliver the usual eulogy at her funeral.
Which is an honor. And I imagine you must have felt like it was an honor to some degree, and that they asked you to do something like that.
At the time, I I viewed it as an honor, but over the years since, I've seen it in a way as redemption. That my mistake with Nina, the little girl at camp, um, was something I was challenged to process. That I did not respond to that letter. Uh, I like to think it changed my behavior, that it improved my practice as a pediatrician, and that possibly being asked to deliver a eulogy was some form of redemption for that.
Well, it's a beautiful story. I mean, there's so much to digest. I guess you had talked about, you used the word redemption, and the word that comes to mind to me is forgiveness. And we are human beings, and the practice of medicine is imperfect by its nature. So how do we recognize that we are human beings? We are prone to making errors, even though our intent is not to do that. Our intent is not to harm. Our intent is to always try to do good, but we sometimes fail to live up to the best standard possible. And then we have all sorts of feelings. We have feelings of shame and regret and sadness. How do how do we forgive ourselves so we can wake up the next day and take care of more patients? It's a hard thing, isn't it?
Yeah, it is, but it's an important thing. It's something we all need to learn to do because we are going to make errors. I continue to make medical errors. Fortunately, most often it's like the Lucian leap Swiss cheese. We make one error, but there are many. It takes a lot more errors to work its way through the Swiss cheese for it to have an adverse outcome. So, fortunately, when I commit an error, and they're not intentional errors, they're just errors that result from being human, from the inexactness of medical science. But fortunately, most often when I make a medical error, my colleagues uh, correct for it. They identify it. Something happens that allows for it to not result in an adverse outcome. And I'd like to think that I do the same for my colleagues. Um, and I think the terminology is interesting. Initially, I would say I felt shame for not responding to that letter. But in looking through the Webster dictionary, shame implies that there's an incorrigible defect in the person that they deserve to be shamed for. I think a better term is remorse, which is a gnawing distress that arises from a sense of guilt for some wrong. Synonym would be self-reproach. But I think the most important term is redemption, which uh, is something that serves to compensate for a defect. But importantly, as you just mentioned, it implies forgiveness, that we acknowledge responsibility for whatever happened, but we also forgive. And I think it's very, very important for physicians to learn to recognize their humanity and forgive themselves, which is actually why I agreed to be on your podcast, because I realized that this event for me as a young, immature pediatrician uh, taught me the importance of self redemption and forgiveness. I'll also add that this is my theory. I'm not suggesting it speaks for everyone, but I think we start in high school being relatively high achievers academically for most physicians. And then in college, at some point we realize we want to apply to medical school, and we realize that we pretty much have to make all A's. We have to excel at everything. And whenever we make less than that, anything less than an A, we feel remorse. We feel like we have failed. And that carries forward into our medical school and postgraduate training, um, and almost can become a character trait that if we fail, we feel like a failure, and we have to get away from that. We have to learn that failure is part of the landscape.
As you alluded to, the process of getting into medical school, there's a sense you have to be perfect. You have to get straight A's. You have to do really well on the entrance exam called the MCAT. And then there's a strive to do well in college and get straight A's and then in medical school and then get into a really good residency that's prestigious or uh, so you'll get good training wherever that is, and then fellowship and beyond. So um, there's a lot of learning lessons to this. I guess where I go with some of this is I think about my own spirituality when I get to some of these discussions because I grew up Jewish in New York and went to Hebrew school and uh, had a bar mitzvah. And part of my Jewish education was learning a bit about ethics and also there's a lot of scholarly wisdom in the teachings of the what I learned the Old Testament or the Hebrew Bible. Um, and I'm unfamiliar with the New Testament, but I know there's a lot that is there as well. And I'm curious if you harness some of your spirituality from the things you've learned from your religious background and how that interplays with your sense of remorse, as you said, and forgiveness.
Well, the I'm Protestant. Uh, I believe in God, and I am quite religious. Um, but my religion believes in grace and forgiveness. That's a very word in my denomination. Um, I recall that one of your prior guests, the oncologist, made the point that none of us know when we're going to die. And we need to live our lives as if that might occur at any time. As it says in the book of Corinthians, at, the, at the winking of an eye, when the last trumpet sounds, we just don't know when our last moments on this earth are going to be. And recall a pathologist friend of mine, who's this state pathologist with the state of New Hampshire, telling me that when he works, one of the thoughts he has is none of the patients, the cadavers that he is examining, they didn't wake up that morning knowing they're going to die.
Mm.
Um, so I think we need to keep that in mind. Um, Now that's getting a little far afield of my story, but just as another aside, one other thing I learned from the letter with Nina was that sometimes we just need to hit the pause button. There's some things that are so important, we need to hit the pause and pay attention to it. And things like that letter are just that kind of instance.
I would say that I'm at the point of my career in the crazy world that we live in pediatric emergency medicine, where there can be chaos and many things all happening at once, and sometimes impossible choices. Um, I try to do as a complete of exam as I can, but sometimes I'm harried because there are other situations happening. But there are times where I feel I just need to stop and spend time with a family. That's not necessarily about the investigation and figuring out what's wrong, but just stopping and spending time with the family. And for me, there's so many reasons why I still love what I do, but one of them is providing that kind of attention and care, and I can even call it love in some ways, deep connection with the family, uh, in a time of need. And to me, recognizing at this point in my career when I can do that and when I should do it, is what carries me into, you know, through a shift and through sometimes, times where I really don't wanna be in the pediatric ER, or it's just crazy and it's just a hard day.
I'm so glad you mentioned that, David, because in the ED, we have the pressure of throughput and getting patients seen, avoiding gridlock, emptying the waiting room, avoiding patient complaints because that seem to be most often about the time they wait. But as you said, sometimes we need to hit the pause button and spend time with that patient. That's the most important thing in the ED. We also need to understand that when our colleagues are doing that, we need to cover for them. We need to understand that they're in a room doing something very important and we need to take care of things in their absence.
Yeah, it's funny, I worked a shift today and we had a, little child that had a, nail bed injury who was 2 or 3 and was just, uh, anxious and, crying and fear and in pain and, really needed ultimately a full sedation for the orthopedic resident to come in and do it, and, there was a thought by the orthopedist, could we get away with something that wasn't a full sedation? And ultimately, one of my colleagues said, "No, I think she probably should have a full sedation, and I'll take care of it," which takes you sort of out of you need to spend 30 minutes to an hour in a room preparing for it, and but it was the right decision, and, we're under a lot of pressure, and at some point, maybe I'll have you back on, and we'll talk about throughput and how to figure that all out, and moving patients and, um, trying to figure out the whole schematic of the pressure that, physicians and nurses and leaders are under to see patients and, get them to their next place. But it's also important to live by, in my opinion, one of the credos is always try to do the right thing, even though it may take time. Even though you need to spend those extra few minutes with a patient, it's so important to always think about, doing the right thing is one of the highest, uh, mantras of service that one can provide. So, Don, when we sort of wrap these up, I kind of I want to ask. I usually ask my guests, and this is a perfect time to do so, because we have learners, we have all sorts of folks who are practicing medicine that are listening. What would be the one or two teaching points that you could share that sort of summarize uh, these experiences that you shared with us today?
Well, one is to always think about what it's like to be on the other side of the bed. We've all been patients. We're all going to be patients. Um, and as you just mentioned with your colleague doing that sedation, if that were your child, you would want that done and want it done correctly. Um, a friend of mine was the chief of family medicine at one of the major University of California medical centers and told me that their daughter, when she was young, had a febrile seizure, which we take as a pretty minor sort of thing. But when they took her to the ED and he was a physician, they were terrified. So we should try to think what it's like to be on the other side of the bed. Secondly, when a patient or family reaches out, reach back. And that's the mistake I made. That hearing back, getting a response to a letter like that is just enormously important to a family. Um, Uh, in a sense, it's a recognition that their child's life has meaning. And when we return the gesture, it acknowledges that meaning. Uh, and then I guess the last thing I'd say is one thing I've learned from that experience and others is it's perfectly okay to uh, connect with families. We're not selling ices at 7-Eleven. It's not a one-time transaction and we're done. Um, there's a relationship there that one needs to be appropriate, but connecting with families is important, even in the ED, more so in general pediatrics, but I think sometimes in the ED as well.
I think that the common thread in some ways outside of just the title human medicine for me is with each of the stories that I hear, I get to know folks, and we've known each other for 25 years. And I think by sharing the story, I know you differently in a beautiful way. And I think it's brave to come on and talk about um, things that are hard and are vulnerable. And honored to be your friend and colleague and brother from another mother. And may we continue to have another 25 years of friendship and as we journey on in life. So thank you so much for being on the show.
Thanks for having me, David.
So thank you everyone for joining another version of Human Medicine. This is your host, Dr. David Spiro. You can follow us on YouTube, Spotify, Apple Podcast, or wherever you get your uh, podcast or vodcast, wherever you digest it. Please subscribe. We'll be continuing to produce episodes every week to 2 weeks. And thanks again for listening.
Thanks for listening to HUMED with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.